All right, let's dive right into this explainer and master the shifting paradigm of oligometastatic non-small cell lung cancer. If you're a radiation oncology resident, this is exactly the kind of high-yield, practice-changing data you're going to need for your daily clinical decision-making. We're looking at a brand new paper from BMJ Oncology that completely reframes how we use stereotactic ablative radiotherapy, or SABR, alongside modern systemic therapies. Because honestly, it's time to stop just counting lesions on a scan and really start treating the underlying tumor biology.
We've got a lot of really high-yield ground to cover today. Here's our roadmap. We'll kick off with the new paradigm, contrast EGFR mutated versus driver-negative disease, talk about sequencing for brain metastases, and then wrap up with some highly actionable clinical pearls for your clinic.
So, let's jump straight into Section 1, the new paradigm of oligometastatic disease.
Historically, if we look back at the classic Hellman and Weisselbaum concept from the 1990s, the definition relied purely on counting lesions, right? We looked at the scans and said, okay, 1 to 5 metastases, boom, you're oligometastatic. And sure, various guidelines absolutely still use these counts. ESMO says up to 5, NCCN says 3 to 5. But we know now that a simple numerical threshold is a really blunt surrogate for tumor biology. As modern imaging like PET-CT and brain MRIs become standard, and as our systemic therapies get incredibly advanced, oligometastatic isn't just a static box you check based on a number. It's an entire biological spectrum, heavily governed by metastatic tempo. That's the velocity at which new lesions are actually appearing.
And this really gets to the core thesis here. Think about it. A patient with slow-tempo, EGFR-mutated disease is biologically totally distinct from a fast-tempo, driver-negative patient, even if both of them present to your clinic with the exact same number of metastases. For the patient with that slower tempo, limited escape sites on targeted therapy offer this amazing window for comprehensive SABR to all lesions. But for the patient experiencing rapid new metastases, systemic therapy alone has to be the priority, with SABR reserved only for highly selective scenarios. It's all about matching your local therapy intent to the patient's systemic biology.
Moving right along to Section 2, EGFR mutated disease, focusing on biology and durability.
When we dive into the published trial data for EGFR-mutated patients, the case for local consolidative therapy is incredibly compelling. Take the SYNDASH trial, giving upfront SABR to all sites alongside first-generation TKIs, literally improved overall survival from 17.4 months to 25.5 months. That is huge. Then you've got the NROG-002 trial showing very similar progression-free and overall survival benefits when upfront thoracic radiotherapy is added. And if we look at the modern era, the North Star Phase 2 trial shows that adding local consolidative therapy to the third-generation TKI, osimertinib, significantly extends the durability of the response. The biological rationale here is just fascinating. By ablating these persistent lesions, we aren't just debulking the tumor. We're actually potentially eradicating the exact subclones that serve as reservoirs for future drug resistance.
But, and this is a very important but, combining thoracic SABR with TKIs dramatically spikes the risk of severe radiation pneumonitis. We're talking about jumping from just 0.4% in sequential approaches all the way up to nearly 5% when they're given concurrently. So for you residents contouring these plans, this means strict dose volume constraints and extremely proactive toxicity surveillance are absolutely non-negotiable. To help build a solid cognitive framework for yourself, try contrasting these two mindsets. In EGF-mutated disease, your goal is to ablate all visible sites to squeeze absolutely every drop of efficacy out of that TKI. Conversely, for driver-negative patients, we have to rely on a highly restrictive approach. In that scenario, SABR is reserved only for high-risk lesions or focal escape. Which brings us right to Section 3, driver-negative disease and our selective approaches.
We have to talk about the massive modern benchmark that is the NRG-LU002 trial, because it provides a pretty sobering reminder. Routine local consolidation does not offer a meaningful survival benefit for all non-progressing patients on modern immunotherapy. The hazard ratios for progression-free and overall survival hovered right around 1.0, no difference at all. But importantly, the grade 3 or higher pneumonitis rate jumped to a full 10% in the local therapy arm, compared to just 1% in the maintenance systemic therapy arm.
So what's the takeaway? Rather than a one-size-fits-all default add-on, local consolidative therapy in the IO era must be highly selective. Like the authors note, it's best positioned as an optimization strategy for very carefully staged patients. Practically speaking, for your clinic, it means you don't just offer SABR simply because you can safely hit 3 targets on the scan. You offer it when safe ablation actually changes the clinical trajectory. Things like targeting a progressing lesion to keep the patient on an effective immunotherapy backbone, or treating a specific lesion that's actively threatening an organ at risk.
Let's pivot to Section 4, Sequencing in Managing CNS Metastases. Thanks to the really high intracranial efficacy of third-generation TKIs, which we saw demonstrated in trials like FLORA, the standard clinical algorithm for small asymptomatic brain lesions has totally shifted. The steps are now systemic first with a drug like osimertinib, followed by short-interval careful MRI surveillance. You then utilize salvage stereotactic radiosurgery, or SRS. Only a focal escape actually occurs. The Starlet joint analysis confirmed this approach, showing that upfront SRS added to osimertinib did not significantly improve intracranial progression-free survival compared to just using osimertinib alone.
Now, of course, you absolutely must deviate from that systemic first rule in specific scenarios. You deliver upfront SRS when lesions are large, highly symptomatic, or if they're actively threatening critical neurologic structures like the brainstem or optic pathways. Additionally, for patients where you're expecting very long-term survival and durable local control is paramount to prevent multiple future CNS events, upfront SRS remains an excellent, well-justified tool in your arsenal.
Finally, Section 5. Let's wrap this up with some high-yield clinical pearls.
Seriously, lock these high-yield takeaways into your mind before your next tumor board. First, shift your focus from simply counting lesions to assessing the actual tumor biology and metastatic tempo. Second, for EGFR-mutated disease, aim for comprehensive SABR to eliminate those resistant subclones and extend the lifespan of the TKI. Third, for your driver-negative patients, be extremely selective, routine consolidation in the IO era is out, symptom prevention and focal rescue are in. Fourth, for the brain, trust those third-generation TKIs for small asymptomatic METs and reserve upfront SRS for high-risk disease. And finally, always prioritize strict organ at-risk constraints. As we just saw, the toxicity, especially pneumonitis, is very real when you combine SABR with modern systemic agents.
As we look forward, we have to ask ourselves how the next wave of randomized trials will continue to redefine these boundaries. We have SABR Comet 10 testing the limits all the way up to 10 metastases, and Target 01 directly comparing TKI alone versus TKI plus comprehensive SBRT in driver-mutated disease. The definition of oligometastatic cancer is no longer an anatomical finish line. It's a moving biological target. So the big question is, how will you use these constantly evolving tools to safely rewrite the clinical trajectory for your patients? Thanks for joining me on this explainer, and I will see you in the next one.